Welcome everyone to the July 14th, 2020 COVID-19 clinical care rounds, critical care, life-saving treatment, and clinical operations. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 critical care challenges and successes in patient care and operations. If I'm a clinician caring for COVID-19 patients, the clinicians I want to learn from are those clinicians with the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who are collaborating on these rounds. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. This Thursday, July 16th, will be emergency department rounds with an emergency department leader from Florida. Stay tuned for announcements for next week's rounds and rounds that come after that. We will continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO rounds we've had to date, we continue to have participants from all states and other countries. For example, yesterday's EMS rounds included participants from Algeria, Bahrain, Ireland, St. Kitts and Nevis, and Saudi Arabia. Participants are predominantly physicians, nurses, and EMS clinicians, as well as we have participation from dentists, respiratory therapists, school nurses, and others. We apologize in advance that we're not able to answer all questions we receive. We pick out major themes from these questions and hope to cover some of those throughout the session. I'm going to turn this over now to Dr. Bruce Struminger.
Thank you, Rick, and thank you to Dr. Patel, who's going to be presenting today, and to our expert panelists, and in particular to all the participants who are joining. So just a few logistic issues. First, we really want your questions, so please put those in the Q&A function at the bottom of the Zoom toolbar, at the bottom there, along where you see also the chat. And in the chat, please put just questions about technical and logistic issues. But Rick will be asking a crowdsourcing question in just a moment, and we'd like your feedback to that question in the chat. The session is being recorded, and your attendance is consent to be recorded. Thank you. The presentation today will be shared in an email announcement that will go out in the next day or two. We will also put it up on our website, along with a link to the recording of today's session. And we'll share a link to that website in the chat during the session today. CME will be available. There should be a link in the announcement that went out this morning from Project ECHO. CME is made available through the University of New Mexico, where Project ECHO is based. We will also be sharing a link about 15 minutes before the end of the session. We love it that you take advantage of the CME opportunity. We also really appreciate the feedback we get through the survey that you'll complete before getting that instant CME. So please share your feedback with us. It's what we need that in order to improve these sessions. Just want to share about how we're using the data that you're sharing with us. We're collecting data through the registration, through your Q&A, through the chat comments and the poll responses. That is shared with the Department of Health and Human Services, Assistant Secretary for Preparedness and Response. All the individual data is kept confidential and is de-identified. We also create some maps and other summaries of the data to share with ASPR so that they can make decisions based on that. With that, I want to hand the microphone over to Sharon Van Arsdale at Emory and at NETEC to give us an update on the webinar series. Sharon.
Thank you so much, Bruce. Good morning, good afternoon, everybody, and happy Tuesday. My name is Sharon Van Arsdale. I'm the Program Director for Emory's Serious Communicable Diseases Unit. By background, I'm an emergency department nurse, and I'm also the Director of Education for Education and Resources from the National Emerging Special Pathogen Training and Education Center. It has been an honor and a privilege to be able to represent NETEC and partner with Project ECHO on these amazing clinical rounds. This really allows us to understand what the needs are. So as you guys are chatting, as you're asking questions, as kind of topics come up, where we're taking notes so that we can then go into a deeper dive with our webinars. So we do have several webinars coming up. They are series. So we have a series with case studies on long-term care. We have a series on surgical cases and considerations. And then starting in August, we'll also have a series on supply shortages and strategies around that. So please check out netec.org for more information.
Great, thanks, Sharon. And next I wanna ask Dr. Rosha McCoy with the AAMC to give us an update on the clinical guidance repository.
Yes, thank you very much, Bruce. Yes, this, again, continuing to remind folks of this open access resource that we have at the AAMC on the clinical guidance from academic institutions, specialty societies, and federal partners. We're constantly updating this guidance. As you know, the science continues to change. Guidance evolves over time, and so we're continually updating this as well. We never expected to have to keep this site up as long as we have, and I know you all probably didn't expect to be doing clinical rounds for this long, but this is where we are. So we're continuing to make sure that the best information and evidence is available to all clinicians. So we hope we find this useful. Thank you.
Thank you, Rosha. Rick, back to you for the crowdsourcing question.
Thanks very much. For those of you who weren't with us at the very beginning, our first rounds was March 24th, and it was critical care rounds. And as our rounds have evolved and we continue to have them, and from the feedback we get, continuing need to make sure everyone has as up-to-date information as possible on successes and challenges with the response from a medical standpoint. A topic that continues to come up, it's hard for me to recall any single rounds where we didn't have the mental health support needs for our healthcare providers, as in ourselves, as a topic for during the rounds. So reinforcing that, and we've actually had some great pearls in response to similar questions like this that have been just extraordinarily helpful and useful. For today's crowdsource question, during COVID-19, what has been the most helpful in supporting your mental health? Again, during COVID-19, what has been the most helpful in supporting your mental health? You know, it used to be the mental health thing around healthcare providers was this touchy-feely thing nobody wanted to talk about, but gosh, as has been pointed out so many times during these rounds, not just need to talk about it, but be able to adapt to be able to like figure out what's going to work for us. So that's the purpose of that question. And please, you know, chat if you're willing and able. With that, I'm going to, first of all, I want to thank a couple of our panelists who show up every time. Sharon and Rosha, you know, you do the pitches for important information from NETEC, and actually can't wait for the long-term care webinars. It's really important. And then Rosha, again, always showing up, sharing the AAMC resources, and that's really been, I mean, the two of you are like beyond troopers, and I just want to like recognize and let people know that it's appreciated by everyone. And at this juncture, I want to introduce our panelist, Vikram. Welcome back, and please introduce yourself.
Thanks for having me, Rick. Hi, everybody. My name is Vikram Mukherjee. I'm an intensive care physician in Bellevue Hospital in New York City and the director of the medical ICU here. And thank you for having me on this panel.
Thanks for coming back. And I'd like now to introduce our speaker, Dr. Bella Patel. She's the Vice Dean of Healthcare Quality and the Division Director for Critical Care Medicine at the McGovern Medical School in the University of Texas Health Science Center in Houston. She also serves as the Regional Chief Medical Officer and the Executive Medical Director of Critical Care for Memorial Hermann Hospital Texas Medical Center. So, Dr. Patel, please.
Oh. Thank you. Thanks for having me. And I'm going to talk a little bit about our journey at managing COVID-19 and the steps we've gone through and what we're expecting in our current crisis as we're seeing a surge. So I'm going to start sharing my slides. So it was easier, just a moment.
While Bella's working on getting slides set up, just as a point of information, because we do 3 rounds a week typically, and yesterday's was our first time in having EMS providers, not the EMS medical directors, present, and it was. If those of you who weren't able to attend yesterday, that one's worth taking a look at the recording of what's happening in streets, homes, and places of work in terms of their response and the challenges. It's worth listening to. Dr. Patel, it looks like you're there. Yeah, great.
Am I there? Okay.
Over to you.
Okay, so we are, as I mentioned, we're in Houston and then the Texas Medical Center and part of Memorial Hermann Health System, which is really the largest health system in Houston. When we look at the entire platform, we are looking at about 11 acute care hospitals, of which all of these are accepting COVID patients. And of course, we have an entire platform of ambulatory and integrated healthcare system that actually takes care of these patients in the ED, in the ambulatory session, and acute inpatient. But of course, I am a pulmonary critical care physician, so I really am focusing on inpatient. We do have 4,000 licensed beds in the Memorial Hermann system, and we do see a huge amount of inpatient and ED visits, and we are the largest Life Flight program. We're also the largest acute care trauma hospital with the highest volumes. And so part of this, as we're focusing on COVID-19, it is also trauma season. And so we're seeing volumes from both sides surge, and we're trying to manage that. As far as the Texas Medical Center, which is the hospital I practice in, it is an academic flagship of the Memorial Hermann system. We do have a large number of trainees. We have over 1,100 residents and fellows and 1,000 medical students. And overall, we have 1,300 beds on this campus. This campus has on average 38,000 admissions a year and about 74,000 ER visits. So clearly a busy campus that continues to grow. So how have we been dealing with COVID-19? In general, we have had a very slow upsurge. We started in March, like most other major cities in the US, and we've started slowly climbing. I think the benefit has been that we've been in communication with all of the centers across the world and other cities that have had surges prior to us. So we were actually fairly well prepared, and when the volume started increasing, we felt like we were learning on a daily basis and adjusting as needed. So here's where we are today. This is the greater Houston area, and this is the number of positive confirmed cases we have in Houston today. And as you can see in July, the numbers are continuing to increase. And as a result, we're seeing more hospitalization and more ICU beds that are needed. This is also the greater Houston area, and you see the red line, which is a 7-day trend of patients needed ICU and med-surg. The one thing that has changed is that initially when we started this process, about 40% of our patients that were admitted to the hospital were actually requiring subsequent ICU beds. In introducing all the therapies we currently have, which includes remdesivir and steroids and so forth, we actually are seeing that about 15%, sometimes 20%, are actually now require ICU level of care. So we are reorganizing our proportion of bed availability for IMU, floor, and ICU. But as you can see in this slide, this is just the number of patients in ICU beds. We're noticing that not only are we admitting patients with COVID-19 who need critical management for organ failure, but we're also seeing lots of positivity across all of our patients. So we clearly have cohorted units for patients that were taking care of COVID-19 patients, but when we look at our trauma units, our cardiovascular units, our cardiology units, they all have COVID-19 patients because they are incidental findings and they actually don't have disease. So we're actually trying to manage that as we're moving forward too. So this is the Memorial Hermann snapshot. This is one of our dashboards, and it shows you the different blocks at the bottom are different hospitals within the system and the number of patients they had as of midnight last night. And as you can see, the surge that we see in the city is a surge we're seeing across the Memorial Hermann Hospital. And we're seeing the total numbers of in-house, which is the very top line, go up, and the dark orange is the ICU beds that are continuing to increase. And currently we have about 230 ICU beds across the system that are holding critically ill patients. So that was slide got a little distorted, but this is kind of our milestone of how we actually proceeded on our campus. For us, March 2nd was when we set up our command center. March 4th was when Houston had their first case. And then the biggest news in Houston is always the rodeo, and it was really big news when the rodeo was canceled on the 11th in preparation for the concern of spread. So as you can see, we've continuously changed day by day, like most organizations have. We rapidly developed an N95 reprocessing measures, and we developed a large processing center on our campus for not only our system, but surrounding systems who needed that support to maintain N95s. We did a lot of testing, different platforms, bringing them up using national and local labs. And then we started our convalescent program. And over time, you can see that the numbers of how quickly the numbers are increasing by 100 on our campus is continued to increase. And on July 6th, we hit our 800th patient. Overall, I think that we've been able to pivot. Every time we hit a roadblock, we've been able to pivot. But within those periods where the time it took to pivot, for example, testing, the flow got sluggish and it got a little painful. But as far as critical care goes, one thing that has been successful for us is using the entire system for an ICU platform. So as you can see in this slide, you see lots of little hospitals designated in purple and in blue. These are our smaller community hospitals that have some ICU capability, but they don't have they may not have the 24/7 presence or the high density of other support structures. And as you can see, the yellow hospitals are the ones that have much higher capability, essentially full capability, except for ECMO. And then the red hospital, which is the one that the Texas Medical Center is the one who does ECMO and does not only have the highest level of support, but the highest level of research opportunities too. So when we started this process, the first thing we did was assess each of our ICUs and understand what their capability was. Understanding that the COVID-19 critically ill patients are not our normal ICU patients. They tend to have a lot more variability. They're crashing all the time, as I'm sure our colleagues in New York City can tell you, that they actually require a much more intense 24/7 presence. And when we look through our entire spectrum, as we're trying to support the smaller hospitals, we encourage them to transfer much more complicated patients to more sophisticated campuses as far as their 24/7 infrastructure was resulted. And then what we did was when patients were stabilized and still continued to need ICU care, but it looked like they were in a slightly longer course and much more stable, then we use those campuses to downstream patients so we could have more room at the Texas Medical Center for ECMO patients, for example. So, so this process actually worked really well. Up until maybe a few days ago when we're starting to hit capacity in most of these hospitals and flow gets a little sluggish. But I would say that overall, what it did was it relieved intensivists practicing in the smaller hospitals, because as their complexity increased and they felt stretched because of their infrastructure, either we provided them the infrastructure or we took those patients off their hands. And so I think that from a critical care management standpoint, I think this worked really well. This is one of our, the other thing that worked well for us was we actually partnered with not only our Memorial Hermann ISD, but the UT School of Bioinformatics. We clearly needed data. We needed it live to make immediate decisions, not only on where to place patients, but to communicate broadly, especially on a large campus like ours, but also across the system. So this is just an example of one of our dashboards. This is for our campus. And it tells you, this is as of this morning, tells you that we have 143 patients, tells you what units they're in, also tells you how many events we have available and what, what our long-term trajectory has been. And so, and this is communicated multiple times across our campus. And then there's system dashboards that are similar that are communicated across the system. And I think without having a quick support of some automatic dashboards, we actually were struggling in the beginning to do a lot of things on paper, by phone calls, by emails. And I think this actually helped improve our flow tremendously and our communication really well. Talking about ICU care specifically, I think the things that worked well for us was that in the ED, when a patient showed up, they had a designated pathway. They had a designated reception area, designated area that their patients were treated, and then a clear path of where these patients moved in and out, including CAT scans, other types of imaging modalities and so forth. So therefore, everyone in that pathway knew how to clean the machines, how to dress for transport and so forth. And I think for us, that was really instrumental in making sure that we didn't have a lot of either contamination of equipment, kept our patients safe, kept our workers safe. So I thought for us that was really useful. The other thing we learned is that as the institutions across the U.S. and the world started seeing these patients, we were noticing a high rate of infectivity among healthcare workers, and we really wanted to go. Obviously, everybody wants zero healthcare workers to be infected by patients. So we want to make sure that we did put layers of support on appropriate PPE dressing, donning and doffing. So not only did we retrain everybody and have them to check off individually, but we actually took lots of our staff that weren't being utilized. For example, as we took down our surgical OR cases to make room for COVID-19 patients, we had a lot of ancillary OR staff, and we used that OR staff to sit in these designated areas and designated routes to make sure that people were actually donning and doffing. So they were appropriately. So they were just our spotters. And as a result, we're really proud that in our dedicated COVID units, we haven't seen a single healthcare worker infected from a patient. So we think that worked well, and it was a good lesson for us. And we started very early when it came to physicians to completely change their schedules. We're an academic campus with UT Health, but we wanted to make sure that they were on a schedule that they weren't doing 20 days in a row. We want to make sure we really fragmented their work so they actually got days of rest between going back and forth. And initially we actually had them off for at least 2 weeks before they came back. And now it's a little bit shorter. We make sure they're at least off 10 days before they come back to work. And so we thought that created a physician workforce that was at least well rested, could disconnect, and because these are stressful areas to work in. And then, like most other organizations, we had a new Code Blue Cross process of how to code patients with COVID-19. We did have a dedicated anesthesia team that anytime a patient who was positive needed to be intubated, that any team could call them, especially with trainees. We want to make sure that we actually got the most experienced people, a person in the house to intubate to decrease exposure time. We also helped relieve some of the critical care teams by having dedicated surgery procedure teams. So if they felt overwhelmed, the surgeons would pop in, and in some hospitals, emergency medicine physicians will pop in to put in the central lines to do and help with other types of procedures like dialysis catheters and thoracentesis to help support that critical care team. And we thought that worked well. And then we actually used some of our other individuals, like our dedicated lift teams and our OR teams, to actually become prone teams. So when we needed to prone patients, we weren't relying on the bedside nurse. That nurse felt supported, and therefore we were ensuring that our time schedule for proning was really well adhered to, and we were decreasing our pressure ulcers. And then, of course, like everyone else, we did lots of things to limit entry into the rooms. We put the pumps outside the rooms. We did a lot of iPad communication. And then we actually, in a lot of the ICUs, we actually use the doors as writing tools to make sure we're communicating back and forth, but not entering and leaving the room on a frequent basis. And then we actually also developed an ethics committee. This ethics committee meets twice a week just to run over all the COVID-19 cases that either are an ECMO or a high likelihood not to survive because of their comorbid conditions or their age, and just to talk over what kind of support we're giving and whether that was appropriate. This is a multidisciplinary team, and I think it's been helpful not only for the entire hospital to understand what's going on in these COVID dedicated units, but also to get that extra validation that you're headed in the right way. So I think as far as wellness goes, I think it contributed to our critical care team wellness. And we also have wellness teams. The wellness teams actually are part of our hospital infrastructure, and they spend a lot of time trying to understand what the stress points are in physicians, nurses, respiratory therapists working in these ICUs. And then they go develop ideas, and they partner not only with our own infrastructure and foundation, but also with external industry to try to figure out how to give a little bit of relief or a sense that people are still appreciating all the work that everyone's putting in. So I think that's worked really well for us. And so these are some of the things, like a lot of centers, we've just been continuing to redesign what we do all the time. We have these ambulatory scanners, so anyone who walks into our institution has this infrared scanner that's as they're walking by, so they don't have to stop to get their temperature checked. We put a lot of glass barriers in place, especially for screening. We developed these hoods for intubation to decrease aerosolization, and we moved everything outside. And of course, at the very bottom, you see our N95 processing area that we put up with the help of our OR nursing teams. So what are we doing for these patients? I think that we're doing what everyone else is doing. A lot of non-invasive ventilation. We actually learned this from New York, that lots of people on high flow oxygen, you could prevent them from getting intubation. So we actually did increase, I think we tripled our supply of high flow oxygen devices, so we could actually keep patients off ventilator if possible. And of course, lots of prone positioning. We're even prone positioning before patients go into the ICU to try to, in hopes of decreasing the risk of patients needing mechanical ventilation. ECMO and other modalities that we're trying on patients. Anticoagulation, as everyone knows, has been the mainstream, and really working with lots of specialists to try to determine how to appropriately anticoagulate, which I think is the big question. And inflammation, obviously corticosteroids, especially after the recent trial. And then we have a lot of immune modulators on trial, on clinical trials that we are managing patients with. But I think our biggest has been remdesivir. We've clearly noticed that after the introduction of remdesivir, that our length of stay in our non-ICU patients has decreased. And again, the amount of patients that then subsequently require ICU care, we've noticed have decreased. So I think that's currently some of the modalities we're using. And if we look at how much remdesivir we've been introducing into our patients across our system, these are all the different campuses. You can see the amount of remdesivir we've given to patients. We actually have a remdesivir committee, and every patient actually has to go through this committee to make sure that we're, because our remdesivir is in short supply, we want to make sure that the patients we think will benefit the most actually get the drug. And so far our remdesivir supply, luckily, since April has been fairly steady with small days of missed opportunity between when we're waiting for supply. But currently, we just got our new supply in yesterday, so we do have adequate remdesivir at the moment. But I think that we think that our future supply chains will be much more steady. So I think that program's been really useful. And as we get more remdesivir, I think that we'll start looking for other opportunities of what types of patients to treat. The other thing that we had to create from scratch was really our convalescent plasma program. Yes, there are current trials going on to see how effective this is, but clearly there's a perception that it is beneficial. So we developed, we started everything and this is the ICU group, of course, doing mass media, trying to get more patients to donate plasma, developed an entire plasma donation site in a part of our ER that wasn't working, partnered with Gulf Coast Blood Bank just to get the supply going. And then we started infusing so we could give plasma to those patients that we think would most benefit. So these are just in the last 2 weeks of how much convalescent plasma we've been transfusing into patients. Clearly, we think that we could triple this number if we had enough convalescent plasma. Right now, again, we're streamlining which patients we think will be most beneficial. And of course, those are educated guesses. But if we had more convalescent plasma, we certainly would give it to patients who we think would also benefit, who aren't so critically ill. And then other things we've done is in critical care, I think, yes, we have new modalities. Well, we have remdesivir and steroids in this patient population, along with potential convalescent plasma and anticoagulation. But I think the basics are important. One of the things that we noticed is when ICU teams get stressed with too much volume, the basics probably get compromised and perhaps they lead to poorer outcomes. So we actually are making sure that the fundamental basics that we know will improve outcomes are very strongly adhered to. And this is just an example of using analytics to determine whether we're doing lung protective strategy. So are we making sure that the tidal volume that we're introducing into our patients is 6 to 8 cc's per kilo, making sure their plateau pressures aren't elevated, and making sure that we are really good about protecting that lung and just to improve outcomes. So these are some of the analytics dashboards we popped up just to make sure that as these critical care volumes are increasing, and those ICU patients are now in areas that aren't used to taking care of these type of patient, that we actually have a COVID-19 critical care consult person who actually then monitors these dashboards, monitors patients in the ED and in non-traditional areas to make sure that the best practices are followed. And then I think the most interesting thing that we found is that when COVID-19 was popping up and as webcasts and podcasts were getting introduced, we wanted to understand how to get into our Houston critical care community. So how do we to our bedside practitioners who are all extremely busy, working long hours. So sorry, my light just went out. Working long hours. How do we get all the information they need and all the questions they answered at their fingertips? And so we decided we did a simple concept called What's in a WhatsApp group. We incorporated about 400 intensivists across the Houston area. And so on a daily basis, if not moment by moment, anything that's new that's published or any new information that's available immediately gets posted. Anytime a clinician is at the bedside, they can ask a question about what to do about a patient, and you have a group of experts among among 2 medical schools and other large centers completely chiming in to help that intensivist understand what's going on. And then the last is we actually, through this web chat, everyone decides who they want to listen to across the country, across the world, about a particular topic. And so we actually then do webcasts based on what the group wants. And this is just a snapshot of how many in a given period, how many questions, what is coming out of that group chat. And really, you can see the majority of them, between 300 and 350 in a 1 week period, were just about management. So we think that the simple concept of a group, a broader group chat has really not only helped standardize what we're doing for COVID-19 patients, it's really gelled the critical care community in Houston like it's never been gelled before. And I think the support that's developed, along with the spread of information, I've never seen as rapid of a spread, and especially to the bedside physician. So I think this is one of our other success stories of how we've integrated the entire critical care platform. And then if individual units or physicians are stressed, they're actually reaching out to the 100 other ICUs that are in the across the campus and across the region to understand how to solve that problem. So I would say this is one of our pearls that we've learned, and we're going to continue even outside the COVID-19 scenario because it's been so effective. And at last, I would say that our challenges, like everyone else, has been how do we get rapid testing. Initially, our testing was sent out, so our lag time was 6 to 8 days in an ICU, which clearly wasn't adequate. So, not only do we now have rapid tests, but we also have learned that because the supply chain for these test kits can be variable, that we've learned to put up different types of equipment, obviously different companies, different supply chains. So when it doesn't arrive on time, we actually can use the next one or use the next one. So we actually now have 5 or 6 different platforms that we can actually do testing. And then that was our other learning point, was not to rely on 1 or 2, but to just broaden it to ensure that we actually can continue to test and manage our patients in a timely basis. And then the next slide is just a slide of the Houston area. The one thing we are doing, we are partnering with the School of Public Health and across Memorial Hermann to understand what the hotspots are and where these patients are coming from. And this is even to my ICU, I want to know where the patients are coming from. And I want to know that somebody is not in that community, making sure that they are doing focused education. And so I think for us, that's also been helpful, is understanding where our highest infective rates are. And lastly, I think just the ICU teams, we've been doing a lot of team building activities. For our campus, if we took our normal medical ICU, which is where these patients would go, now we have 5 other ICUs that are full of COVID patients. And the teams are different. The physicians are physician and nursing and respiratory therapists are all very different, and they're not used to working together. And so we've done a lot of activities to build teams to make sure that we're supporting that stress of not understanding how teams function in a medical ICU versus a surgical ICU, for example. So that's been really helpful. And obviously, without the team, we couldn't really get the great outcomes we've had. I do worry that we have had actually great outcomes, great mortality, because I think we've had this steady increase and we've been able to prepare and compensate. But I guess my last worry is, as the volumes go up, at some point we lose that luxury and we start stressing the system more and more. So I'm hoping that our volumes in Houston start going down. So that's all I had this morning. I'll stop there.
Thanks very much, Dr. Patel. Really appreciate the presentation. And there was one slide, before I make my comment, for the panelists, I'll take 1 or 2 questions from the panelists before we go to the polling. But I do have one comment question. And Belle, if you could unslide share. There we go. We got the Hollywood squares back up. Thanks.
Okay.
So that one slide that you had about how you were treating patients, it's fascinating to me. What you had up there is almost like a snapshot of the evolution of the over 40 rounds that we've had and the evolution of where we are today. It was absolutely fascinating. You get the anticoagulants up there, et cetera, et cetera. There's one question that was sort of a theme I saw in chat questions, et cetera, about your institution and messaging to the community. It was that theme, okay? And I heard, loud and clear about the convalescent plasma and that particular piece, but and that theme of, okay, what's our role with the community in terms of messaging, outreach, whatever it is you want to call it, because certainly we're not like before January this year anymore. So tell us about that from your perspective, especially since, I mean, I was at HRMA a long time ago. It was huge. I mean, I can't even imagine. I mean, I've seen the pictures, but yeah. So what is it that you're doing around messaging these days?
I think for messaging, we've really been talking about the basics. We've been on TV, in the newspapers and so forth. Every which way we can get to patients, or patients and the community in general, is just the basics. You know, wear your mask, hand hygiene, keep social distancing, because we want to make sure that for the patients who do require hospitalization, that we clearly have adequate capacity. But we really want us to have the healthy, you know, the community stay healthy. So we've been doing almost on a weekly basis, just to remind people the same message that we've all been giving. But and then I think, and then of course, the other messages has been around convalescent plasma, to make sure that you donate, and trying to make sure that we provide all the links and resources for people to donate close to them.
Thanks very much. Vikram, Sharon, or Rosha, any of the three of you before I go to polling? Sharon?
Yeah, so there are lots of great questions here and great presentation. Thank you so much, Dr. Patel. I am really interested in your dashboard. I think that anytime we have data to help drive or predict, so I wondered if you could talk a little bit more about that. How do you get it? Is it electronically pulled, or that'd be great.
Sure. So all of these dashboards were built just off of the usual data stream, and using Tableau on top of that. And so the way we've built the dashboards is we actually go to the end user. So we go to the bedside teams and the managers and the directors and say, okay, what data do you need to make decisions? And what data do we need to keep patients safe, or employees safe, or decrease utilization? So those are the simple questions we asked. And so most of our dashboards were built, they're all actually built on Tableau, and then people can either log in, but we know that people get really busy. So we've really just embedded an automatic push out, so people can just see it on their cell phones and they know exactly what's going on. And so, and if they wanted to then click on it and then get into deeper information, they can. So, so we built them really just live as we're starting to see COVID patients. And so we have different types. We have ones for patient flow, which the next tab actually talks about testing, to figure out where patients are testing, which ones are, have had the second negative, that's the second one back that's negative, which ones are going to which labs to understand what the delays are, and so forth. So, and we have dashboards on testing turnaround times, because obviously that impacts our flow. So I think that we just wanted to make sure that before we put a lot of energy into really nice, beautiful dashboards, that they were going to be used. And I think that's what we always make sure is that is the data actionable, and only then will we then get our teams to start building them.
Thanks, Dr. Patel. Vikram. And then Echo, we're going to do Poland right after Vikram. Sorry, you got to cue it up,
Thanks, Rick. Wonderful talk, Dr. Patel. And I love the slide where you showed how the patients were moving from one facility to the other depending on the acuity of illness. Goes to show how a strong network and resource share. I guess my question is, you have your flagship as the ECMO referral center. Were you getting a lot of patients from your community hospitals who required ECMO or were transferred for ECMO eval?
Right. We do get a lot of patients who are referred for ECMO evaluation. Because as you know, that these patients have to be able to be transported on a normal basis. And we have helicopters that will go get them. But in order to actually have adequate ventilator support they may need to be called a little bit earlier than the absolute time that they need ECMO. On the other hand, we do have an ECMO team that actually gets on our helicopters, goes to these communities to cannulate the patient, to bring the patient back if they're too unstable to be transported. So, so we do have a lot, but having said that, when we realized that about 80% of our patients that were getting referred for ECMO probably just needed some advanced ventilator strategies, we actually then have a team of pulmonary critical care physicians who actually will talk to that site. And they will go through, all the potential ways of improving oxygenation or reducing carbon dioxide. And now we're finding that a lot of the times the patients can actually stay where they are, just with a little bit of extra, brainstorming about what else they could do for the patient. So we're now trying to keep patients there as much as possible, but we do have a large ECMO group.
If we can put up the polling, but as we do that, one of the things that's most fascinating to me in hearing your presentation is, and you are articulated already, you had some time to think about this and essentially put things into place. You know, Vikram, I remember your presentations, your colleagues from New York, and how it was like so sudden and sort of like the evolution of how different institutions based on what they had the benefit of, you know, the sad experience of New York, and yet you know, we're all still trying to figure this out as we continue to evolve. So anyway, thanks for the presentation, Vikram. I'm really glad you were on for this one, because you know, that sort of like hurry up and like pull it together, and you know, Bella's had a little bit of the advantage of learning from those experiences. So let's go to the polling, please. So those of you like that are still on, and I know people have 1 o'clock meetings or lunch appointments, I got that, but this will take about 10 minutes. Then we'll go to, yeah, good. This was an easy question. Yeah, not hard. So, and there's no exams or anything like that, no grades. Get off of your email and help us out with the poll so everybody can see what's going on throughout the nation. On the polling, and I've said this every time, or have definitely been saying it recently, know that the polling results, everybody gets to see these. They are archived, so people can go back to them. They're in the public domain. And at HHS ASPR, I share the polling results on a daily basis back with HHS, the Healthcare Resilience Work Group. So they're aware as well. And actually, based on it, sometimes we have changed some approaches based on what we've seen in polling. So indeed, it's helpful for everyone. Let's see, and also the responses, they are de-identified. So if you're concerned about, is my response in particular going to get pulled out? No, we're not doing that. Okay, so yeah, other discipline physician, looks like that's the #1 for sure. Okay, next. Oh no, EMS paramedic or EMT was the most frequent response, and then other discipline physician. Next one, please. Okay, this is around crisis care plans. Today, our organization's crisis care plans have been implemented and adequately address challenges. Second one, have been implemented and do not adequately address challenges. There's a big difference there. And then are completed and ready if needed, are being developed but not ready, are not being developed are the options. Yeah, we got about 30% of the participants have voted already, which is really good. Let's keep going on this. Might take this one might take a little thought beyond, like, I am actually a nurse or respiratory therapist, so. All right, just a few, about 5 more seconds. I have about 40% on this one. All right, let's stop there. Most frequent response was 30% of you said implemented and adequately address challenges. 17% do not adequately address challenges. 22% for both completed and ready are being developed but not ready. Okay. All right, thanks. Next. In the past 7 days, distribution, it's like a lot of different terms for it, but load balancing across your system of critically ill COVID patients. So it's critically ill COVID-19 patients across hospitals in our region has been balanced, not balanced, and don't know. And actually, Vikram, this particular question comes back to something you and your colleagues in New York had talked about, the load balancing very early on. I mean, I remember those rounds very specifically. It's like, let's see how we're doing now. I mean, people know it's like really important. We always knew it was important, like transferring patients, but wow. We got 43% of you voted. Let's see if we can get a few more in the next 5 seconds or so. All right, let's stop there. 36% said balanced, 10% said not balanced, and 54% didn't know. Okay, all right, next. All right, and this is not about what's actually happening, but the coordination issue. So distribution of critically ill COVID-19 patients across our hospitals in our region has been well coordinated, not well coordinated, non-existent, and don't know. This one's been pretty interesting to watch. And by the way, panelists and hosts can't vote, so we're like, but I'm seeing these results and that they kind of like are changing like every second in terms of like the highest frequency or most frequent response. All right, let's stop there. 48% of you voted, almost half. Well coordinated, 14%. Congratulations, coordinated, 16%. Not well coordinated, 12%. Don't know, 52%. All right, thank you. This is around ICU shortages, okay? So ICU, and there's an option in here, like I don't work in the ICU, so there's, or don't know, so there's a lot of options. So everybody ought to be able to participate, even if you don't work in the ICU or you don't know. There's options for everybody. So it's shortages. And you get multiple options. So I'm going to leave this one up here a little bit. All right, like 5 more seconds. All right, let's stop there. So the past week, the most frequent response was 20%. Nurses, I see 20%. Yeah, nurses is the highest or most frequent response. I'm particularly interested in the remdesivir, well, ventilators, remdesivir, dexamethasone is not too many. All right, thank you. Next, and Dr. Strominger, while we're doing the next poll here, in terms of like questions, I know you saw a few that were particularly of interest, and I might get you to ask some of those of our panelists and speaker. Which of the following ventilatory support strategies are being used in patients prior to admission? So if you're in the ICU, what are these patients coming with already? And if you're not in the ICU, you get to answer this one too. So prior to admission to ICU, what's being used? Okay, about 5 more seconds. All right, let's stop there. Most frequent response is high flow nasal cannula. That tracks with, but multiple other interventions as well. That tracks with similar polls we've done over the past week or so. Thanks. Next. Clinicians in our organization have treated COVID-19 patients with select all that apply. And for those of you that don't prescribe or administer drugs, you've got an option there too. So everybody has the opportunity to vote, except for me and the panelists and speaker. Dr. Patel, reminds me of that treatment strategy slide a little bit. As soon as I saw it, well, I'm tracking pretty well. About 5 more seconds. All right, let's stop there. I think people can see that for themselves. It's very, to me, it's very fascinating. Remdesivir and dexamethasone, like 35, 37%, close to each other for sure. All right, next. I think there's only a couple more questions. I know a critical care physician or nurse who has been unable to work 1 or more shifts due to the mental health impact of the pandemic. We did this with EMS rounds yesterday for EMS providers as well. And I don't want to leave this one off the table when we're having rounds. It was importantly identified and want to make sure we keep tracking this. All right, let's stop there. 43% of you voted. 31% said yes, they did. 51% said no. All right, thanks. Next. Intensivists in our ICU are training non-intensivists to provide critical care. I was told in the chat on a previous rounds, I was not supposed to wager on any of these, so I'm not doing that anymore. All right, just a couple more seconds here. Let's stop there. All right, yeah, how about that? 30% said yes. Interesting. All right, next. There's a couple more questions on telemedicine, actually. Our ICU, and you got these ones, you got to read these. You just got to read them, okay? Providing telemedicine support services, not providing but could provide telemedicine support services, receiving telemedicine support services, not using but could use telemedicine support services, or don't know. Another couple of seconds on this one, we'll stop. It's about 43% of you voted. All right, let's stop there. Wow, look at that. 16% are providing telemedicine support services. I'm actually surprised and gratified by that. Next. Echo, that might have been the last one. Yes, maybe. All right. Thank you. Bruce, did you see a particular question that you thought was really we need to ask?
Maybe super quickly, Dr. Patel,
Yeah.
thanks for the great presentation. I did see in the chat a couple quick questions that I'd love to ask you. One, I think super easy. Were you using an incident command structure to coordinate your response? The other is, what kind of a triage system were you using for remdesivir? How are you deciding which patients would receive remdesivir?
So yes to both. We did have an incident command center that was started immediately, actually 2 days before the first case in Houston was tested. So, and we've been using that incident command center throughout. And not only do we have a local hospital-based incident command centers, but then we have a corporate, a system, Memorial Hermann system-based command center to make sure that all the entities are, communicating and information, as well as equipment is flowing between the hospitals. And for the remdesivir, we actually use the criteria for the remdesivir trial. So we know that in the trial that those patients certainly benefited. And if we had a limited resource, we went straight to the trial and said, okay, this is the patient population we're going to treat. And so I think when we get a broader resources for remdesivir, then we'll then broaden those criteria.
Great, thank you. And Rick, back to you. And I've got.
Thanks.
Thank you.
Yeah, people have 1 o'clock meetings. They got 1 o'clock appointments. We got that, and it's absolutely okay. I mean, people got stuff to do. But Dr. Patel, any last comments, words of wisdom from your experience that you want to share with those that haven't hit this yet?
I think that it's always plan ahead. So I think for critical care, the only way we're managing the surge is that we're planning for the next ICU today, about what resources we'll need, how to build those teams, and so forth. So you need to always plan 2 steps ahead to make sure that you're not caught off guard. Because I think when we can't manage the surge, obviously that's when we start having poorer outcomes. So I would always say manage the next floor unit, the next ICU, and continue to evolve it as the volumes in your area start increasing. And obviously, it's always easy to undo things you've done because obviously you'll need those resources elsewhere. But that's one thing I can't stress enough is plan ahead.
Thanks very much, Dr. Patel. And for our participants, thanks for joining and participating in, there's a lot going on in the chat and the QA, and there's just a lot going on. Our participants are not shy, and great dialogue there. For our panelists, particularly Vikram, Sharon, and Rosha, really appreciate your joining us, and realize people have to leave. And Dr. Patel, it's really a great presentation. I mean, it really kind of synthesized a lot, and just deeply appreciate your time and being able to share. Those who haven't hit it yet learned a lot from you, as I did, and I've been doing these rounds since March 24th. So thanks all. Thanks to Project Echo for the platform, and we will see you on the next one. Thanks all. Bye.